Good morning. What is happening? Hope you guys are doing fantastic and certainly welcome to Tuesday training. We are live here in Austin, Texas. That's the way we do it right here in Insurance Syndicate headquarters. So this show airs every Tuesday at 9 a.m. We do occasionally do some pre-recorded stuff, but most of the time we are doing it live. And I am always the host of the show for the most part. Occasionally Joe Campert, my partner, steps in for me. Sometimes we got guests. Sometimes it's just me, the star of the show, which is what we're going to do today. And today is going to be a heavy-duty Medicare episode. Medicare is my jam. For most of you out there that know me know that, right? That is my whole thing. And we're going to dive into quite a few things on Medicare. One of them obviously being the big shakeup that everybody's been talking about that happened not last Friday, but the Friday before, when Medicare, or CMS, the Center for Medicare and Medicaid Services, dropped a giant proposal in our lap that they're planning to make changes to the Medicare Advantage space come 2025. And I'm going to talk to you a little bit about that today. It's already been a pretty hot topic. Nobody knows exactly what's going to happen for sure. Let's just set that straight right up front. We're all speculating based on what is in that document. And at this point, like I said, it's just a proposal. This is just ideas that CMS wants to do in 2025. And now it's time for the lawyers to hash it out, right? And then we'll see what happens. We will likely not find out any more, truthfully, until probably late 2024, to be honest with you. I mean, if you think about the rate at which they move on these things, they don't move fast usually, right? They tend to move slow, and they tend to announce them last minute. Right? Like for the year 2024, we didn't find out about some of the specific marketing and regulation changes that we as agents had to cooperate with until I think it was July or August of this year at best. Maybe it was even September for rules that we're going to start in October. So they're not going to give us a ton of notice. Let's just, understand that and brace for that. But we will dive into it pretty heavy duty. So I appreciate all you guys tuning in. We are going to have some great news today, as well as many more things. So certainly stay tuned. If you're a Medicare geek like me, you'll probably enjoy this episode. If you're not a Medicare guy, but you're interested in it, you'll probably enjoy this episode. And if you're not a Medicare guy at all, maybe you should go call your leads today, or at least during this hour. That might be a better exercise of your time. But first and foremost, before we dive into everything, I want to make sure that you are aware of our sponsor. You can see him around the frame here, which is MetaZeus. Man, if you're a Medicare agent out there and you're not familiar with MetaZeus, you need to get familiar with it, because this is a piece of tech that is outstanding for the Medicare Advantage space, specifically Medicare Advantage and drug plans, technically, anything that exists in that little world. And what it does, very simply, is it keeps you up to date in real time on the status of your Medicare Advantage or prescription drug plan book of business, right? And this is important because if you are an agent out there writing Medicare Advantage, if your enrollment gets replaced, if it gets flipped, whether it be during a special election period, during the annual election period like we're in right now, or during the open enrollment period that starts from January to March, generally you won't find that out until 2, maybe 3 months later, when you get your chargeback. And that's not very conducive to running your business. Let's be honest, right? You don't find out for 2 or 3 months that one of your clients left you. You're not really sure why they left you, and there's really nothing you can do about it at this point except stomach the chargeback, go write more business to replace it. But with MetaZeus, you can monitor your book in real time. And if someone flips their plan during one of the qualifying election periods, you're going to know pretty much immediately, within 24, maybe as much as 72 hours. But you're going to find out very fast, and you will be able to call that client, or that prospect now, I should say, that ex-client, talk to them and find out what's going on. We have already managed here at Avila, we're using the platform. We've already managed to identify a few applications that are getting moved, and we've been able to step in there, run some interference, and get that client back on our book of business for next year. So, we are seeing some tiny chargebacks on some of those for the last quarter of the year for people that were able to move some of our DSNP clients, different things like that. But we're able to get them back in 2024, get them back in our book, get our perpetuity back to where it should be. So excellent, excellent platform. It's only $89 a month to sign up. And if you're writing, if you're writing 100 apps a year, let's just say that, you should easily be able to find 3 to 5 apps that you can save using MetaZeus, and the platform will pay for itself. It is a phenomenal platform. It's super easy to use. You just upload your book of business in a CSV file if you want. You can enter them manually, and it will. And you only need 2 pieces of data. You need their date of birth and their Medicare number, their MBI number. If you have those 2, it will come back and confirm all the other information. It'll show you what their current plan is. It'll show you what their future plan is, and it'll even tell you what their LIS levels are. So great product. Matter of fact, there was one person in our group that we saw, hey, this person is actually fully qualified for Medicaid. And we hadn't known that already. So we were able to actually go back and provide her additional love, additional service, get her qualified for Medicaid, get her on a proper plan that's going to give her even more benefits. So check it out. We'll make sure I'm sure you've seen it. There's a demo floating around the group as well, but definitely check out MetaZeus. It's an outstanding platform. Now, moving along to some news. We have a little bit of news first before we dive into the meat of this. Let me get my screen share working. You have probably, see if there's a better way for me to share this with y'all. Not that one. That one's a little bigger, but then you can't see me. So that's no good either, is it? All right, let's try this again. All right, we'll just do it like this. Nice and simple. All right. So you've probably seen this one. This one's been circulating around the interwebs and on some of the different Facebook groups for a while, but Cigna Health Spring, if you're not familiar with Cigna, when it comes to the Medicare world, they have 2 contracts. They have Cigna Supplemental Benefits, which is all of their ancillary products. Medicare Supplement, cancer, heart, stroke, dental, vision, hearing, hospital indemnity, final expense, yada, yada, yada. Then they have their Medicare Advantage side from when they acquired HealthSpring back in 2012, as I remember. And recently they were under the gun. I shared an article maybe 3 weeks ago or so that they had to pay back $172 million due to a lawsuit from Medicare for them basically overbilling Medicare for clients. They were basically claiming that clients were sicker than they really were so that they could sell more services and get a higher reimbursement back from the government. If you don't already know how these Medicare Advantage plans work, they are subsidized by the federal government, right? So they get payments from the federal government for every enrollee as well as claims, et cetera. So they were overbilling Medicare basically and getting a lot more money to the tune of $172 million. That is 9 figures. That's a lot of cash. That is a lot of cheddar. They had to pay that back. And then this article just came out from Reuters, I think is how you say it. I don't know. But they are exploring shedding their Medicare Advantage business. And when I first saw this, it didn't come as a surprise to me because Cigna's been in trouble quite a bit since 2012 when they did purchase HealthSpring and roll it out. They've been sanctioned at least once. I think they've been suspended twice from even being able to participate in the annual election period and things of that nature. One of the suspensions was as long as a year, as I remember, that they had to sit on the sidelines, not taking on new customers. Huge penalty. And then now they're back in the news, had to pay $172 million in overpayments because they were claiming clients were sicker than they were to get more money. And now here they are looking at getting out of the business. So this will kind of go through it a little bit. This article isn't really the one that I want to dive into. The one that I want to dive into is the next one. So understand that Cigna, after all of their wonderful exploits in the Medicare Advantage business, is looking to get out. Why are they looking to get out? Or maybe how are they looking to get out? So let's check this one out. Right here, this is an article that I found on Stat, reporting from the frontiers of health and medicine. And if you look down here, it says, is there a bigger move being planned at Cigna? And well, there apparently is. A report from Reuters last week said Cigna is looking to sell its Medicare Advantage business, which covered 600,000 people as of September. Cigna is a very small player in Medicare Advantage, and its MA plans have been messy and controversial since it bought HealthSpring back in 2012, right? But Cigna's MA business is still sizable, growing, and profitable. Look a little further down, and what does it say? It says, well, we would see this action being one component of a potential pursuit of Humana as an acquisition target, with the divestiture being a proactive move to reduce antitrust risk. So they are targeting Humana as an acquisition partner so that Humana come and scoop them up and hopefully improve their Medicare Advantage business, and Cigna will get out of it, basically. Cigna is really heavy in employer, right? They're one of the biggest employer providers out there, commercial health insurance. And Humana is pretty much almost entirely Medicare Advantage. They do have certainly Medicare supplements, prescription drug plans, and Humana left the commercial or the group sector recently. So when you look at it from that aspect, it says that this would have no insurance overlap and it would not trigger an antitrust review. But there is one other issue. A combined Cigna Humana would still have overlap with their pharmacy benefit managers. Cigna owns Express Scripts, which is the second largest PBM, according to Adam Fine of Drug Channels, and they certainly are huge. And Humana owns the fourth largest PBM out there. So, considering how the Federal Trade Commission is already scrutinizing PBM market power, seems like that could be an insta-block on that deal. But I thought that was pretty interesting. So if that's going to work, Cigna is not only going to have to shed their Medicare Advantage business and sell it, I'm assuming they're going to have to sell Express Scripts too, if that's the deal they're looking for. But pretty interesting there. So Cigna's looking to get out. Here's another good one for you. Check this out. If you're out there selling Medicare as an agent, whether you're an independent agent, whether you're a captive agent, etc., this article should entice you a little bit. Insurance agents have been complaining about call centers. Well, let me rephrase that. Medicare space insurance agents have been complaining about call centers for quite a while, saying that they don't provide the level of service that an independent agent provides, saying that they are generally unscrupulous. They don't always follow the rules. They're cold calling illegally. They're saying anything they can to get someone to flip their plan, and they're not completely wrong. A lot of those things are certainly happening in large call center aspects. Shoot, those things happen at independent agent level. Call centers aren't the only guilty party in the Medicare space as to why we have a lot of this regulation that we have now. There are independent agents out there working on their own, out of their own little house, running field appointments and doing things unscrupulously as well. There's not that many of them. Truthfully, if you look at it, I mean, most of us are out there doing the right thing, but all it takes is a couple of bad apples. And then we already know how the government behaves, right? All they need is one bad person, and then they just apply the rule to everyone, right? One asshole makes a bomb with shampoo, and then the rest of us have to travel with shitty hair. Just kind of how it goes. But this is pretty cool right here. I have to say, I kind of like this one because this means that there is less competition for me through the rest of AEP, right? So let's look at this article. Medicare and ACA call center workers strike. And if you're out there in the ACA space, this should really excite you because the ACA space is ripe with people just flipping AOR changes and doing all kinds of wild, wild west shady stuff. But it says hundreds of Medicare and ACA call center employees have walked off the job in 7 states over better wages, benefits, and the right to unionize. Now, the recruiting side of me says I want to get a list of all those people so I can give them better wages and show them how to build a business and actually make real money in the Medicare space. But looking through this a little more, it says hundreds of Affordable Care Act and Medicare call center employees of federal contractor Maximus walked off the job on Thursday, November 9th over better pay, affordable health care, and the right to unionize. The Communications Workers of America, CWA, which organized a press call for the workers, said in a statement that 700 workers walked off the job, calling it the largest federal call center strike in history. Workers at call centers in Arizona, Florida, Kentucky, Louisiana, Mississippi, New York, and Virginia were on strike, adding that the Mississippi and Louisiana centers were largely shut down. So that's 700 people out there, 700 agents that are no longer calling the same prospects you are, whether it be in the Medicare or the ACA space. Now, Maximus went on and says, hey, there's no disruption in service for the tens of thousands of Americans seeking to sign up for essential benefits. Certainly not. There's plenty of agents out there that can sort them out. But certainly that walkout comes amid Medicare's open enrollment period, which began on October 15th, ends December 7th. I mean, we're right in the middle of the ACA enrollment period too. So this is an interesting time for all these agents to jump out. But here are their demands. If you look on a little further, they want a required wage of $25 an hour, which the CWA said is commensurate with what federal employees make. They want to ensure that workers have affordable health care. They apparently want to investigate racial disparities and potential obstacles to equal employment opportunities at Maximus. And they want to investigate Maximus to ensure it is a responsible federal contractor. So there you have it. Call center workers are on strike. They want more money. I mean, if I'm a call center agent right now in the middle of the busiest time that I'll ever see, just go write more business, man, and make more money. I don't understand the issue. I'm assuming some of these call center people are just making an hourly rate. Maybe they're getting no rip on the business that they write, but that just seems bizarre to me. I would think just write more business, get paid more money, but maybe these people are strictly just making an hourly wage and Maximus is ripping all of the commissions and the overrides. So pretty crazy. A lot going on right there. But as an agent, you know, that should kind of excite you a little bit. That I have less competition out there right now. Now, moving along to, where'd it go? Here it is. Moving along to the main topic today is this CMS proposal that came out. It was dropped in our lap. It wasn't last Friday. It was the Friday before, as I remember. Elle Denning and I touched on it a little bit on Winning on Wednesday, and then Glenn Shelton and Christian Brindle did a lengthy, like maybe 2-hour live or recorded episode. I think it was a live episode where they talked about it. They kind of went through different parts of the bill and picked it apart. And I actually posted an article in the group. I posted this article right here a week or two ago. It says Medicare wants to crack down on payments to insurance brokers, right? This is from Axios. And this goes through a few of the bullet points of what they're targeting in that bill for 2025. It's mainly targeting compensation. There are a few other little details that are mostly fall on the Medicare Advantage insurers, right? But for the stuff that us agents, brokers, agencies, FMOs, NMOs are concerned about, is the compensation piece that they're really targeting. So I had posted this article in the group, and then below this article, you'll actually see a link to the full 486-page document right here from the Department of Health and Human Services, 486 pages. It's huge. I still haven't read the whole thing. I've been scanning through it and reading quite a bit of it, and most of it, like I said, doesn't completely fall on us. The big part that's really going to affect us is what they're looking at in regards to compensation for the most part. And there's a few things that they're going after on this that I'm going to talk to you guys about. Now, if you want to review this whole document, like I said, it's linked below this article right here that is posted in the group. So if you can find this post from me in the group, just search Tony Merwin in the Insurance Syndicate. You'll find this article, and then linked below the article is the actual, is this document from Department of Health and Human Services for public inspection. And if you want to read 486 pages, knock yourself out. But if you don't already know the trick, pull up the document, hit Control F, search the word compensation, and read those items, because those are the items that mostly will apply to you. But I'm going to go through some of them for you right now. But I want to jump back to this tab real quick. So this is a newsroom. This just came out last week as well. And again, this also kind of streamlines some of the items. It also has a link to the article built into it, so you can pull it right here. But this fact sheet just kind of goes through a few of the items that they're talking about in regards to how they want to make changes in quite a few things. This one actually goes through some of the utilization management, a lot of the stuff that will actually fall on the Medicare Advantage plans and the insurers, not so much us, right? But I'm going to dive into my 2 cents, so to speak. So if we look at this real quick, right, and it says it's pretty simple. Medicare wants to crack down on payments to insurance brokers. Hey, I'm an insurance broker. You're probably an insurance broker. That sounds like it's going to affect me, so I'm interested. So it says the Biden administration's closing loopholes that it says allows Medicare Advantage insurers to encourage brokers to steer consumers towards certain plans. Now, many years ago, they capped, I guess cap's the right word, they standardized the Medicare Advantage commissions. The idea with standardizing the Medicare Advantage commissions was to remove bias from the insurance agent, right? And this was really true many years ago. It's probably still true today for the most part, but agents will tend to be biased towards a product that pays them more. It's not rocket science, right? At least in the short term. And I would say in a lot of cases, that's a short-sighted agent. There's another flip side to look at that an agent might be biased towards a product that pays him more for the long term, right? And those are the agents that generally do better in the business. If I know that I can provide my client with a product that they're going to keep, that they're going to be happy with because it's a renewal-based compensation system, then technically I make more money by selling something that they're going to keep for the next 10 years with little to no problems versus selling them short-sighted and let me just sell them the product that's going to pay me the most today. But that's what they're cracking down on. They don't want agents doing that. And I don't blame them. I don't want agents being biased towards payments when it comes to my healthcare or my products or anything that I need. I think we would all tend to agree on that. By the way, as I'm going through some of this, man, if you got any questions, put them in the chat. I'm happy to address them as we go through some of this stuff. So they want to remove bias, and I'm just going to go ahead and remove this article. No, not yet, because I want to get onto this thing. Give me a second. I also found some redundancies in here. And I'm just going to jump over to page 6. Because in this thing, this ridiculously large proposal, you will see areas where they talk about where they talk about creating a flat payment system for agents. Technically, that flat payment system already exists. It's already in play, right? Because if you're an insurance agent in the Medicare Advantage space and you are direct paid by the insurance carrier, this probably is true for some of the LOA models out there too, unless they're just paying you a low substandard commission. Doesn't matter if you sell Blue Cross, Aetna, Humana, United Healthcare, WellCare, Scan, Devoted, Anthem, Amerigroup, Elevance, whatever hell their name they're going by this year, or any other number of the Medicare Advantage plans that are out there. If it is a commissionable plan, and most of them are, granted, there are some pockets and areas where there are non-commissionable special needs plans and so forth. But if you're out there selling a Medicare Advantage plan, it does not matter. It doesn't matter who you're selling. You're going to get the same money every time. Right? If it's the year 2024, which it should be, you're going to get paid $611 for $611 for every app you write if it's brand new to Medicare in 2024. AAP business that you're flipping right now, you're getting paid $305. That is the going rate. Doesn't matter who you sell. So to some extent, they've already succeeded in creating a flat standardized compensation rate that should prevent us from being biased, because I'm not making more money if I sell WellCare versus selling Humana. So I, as an agent, shouldn't be biased. The funny thing to me is the only people they're removing the bias from are the unscrupulous agents. I'm still biased. I'm still going to be biased towards writing them for the plan that I believe will still be there for them next year, that will still give them the same service next year. I'm biased towards the plan that they're not going to want to change for the next 5 to 10 years. Why am I biased by that? Because I have a higher lifetime value on that plan than I do constantly flipping them around or losing them to another agent because I write them a shitty plan, pardon my language. Right? I'm biased towards the plan that's going to stay on the books, the plan that's going to keep my client from calling me and complaining. I don't have to be biased by them. Oh, I get paid $5 more for this app or $25 more if I write this product over that one. No, I'm biased towards the one that stays on the books the longest and reduces the number of phone calls that I get complaining to me because it's crappy service or a crappy product. And I'm of the opinion that if you're an agent out there, that's the bias that you want to have. And it's the bias you should have, right? But so they want to remove the bias from us making more money on any given product. Well, since we're already standardized from it at the agent level, right? We're getting 611, 305. What they're really going after is the money that's above us, the upline money, the overrides, the bonuses, the marketing co-ops, the HRA payments, the VBE payments, all those little extra incentives that will bias some agents out there. And I don't blame them, man. If you're an agent out there and you're getting $10,000 in co-op money from your FMO through Humana, and of course that's given to you with the idea that you're going to write more Humana business. Otherwise, you're probably not getting those co-op dollars next year, assuming anybody's actually paying attention. And I'm of the opinion most of them aren't. And I'm of the opinion most of them don't even care. There's like, just pass through the money. Because let's face it, if in most cases, and this isn't going to be true with everybody, okay? Nothing's ever absolute in this industry. It's not ever black and white. It's all kinds of shades of gray. In most cases, your upline, NMO, FMO, agency, whatever nomenclature you want to throw on them, when they get marketing money to give you, in most cases, it ain't their money to begin with. They're just taking Humana's money or WellCare's money or United Healthcare or Aetna, whoever they're getting the co-op dollars from, and they're just moving it to you, passing it straight through, right? It's not their money. It's really not even coming out of their pocket. And this is going to vary from one FMO or NMO to the next, right? Some of them might go, hey, let's keep some of those marketing dollars for our own profits, and we'll pass through these to the agents that are doing the most business with us. And certainly they're going to provide Humana co-op dollars or Aetna co-op dollars or UHC co-op dollars to the agents that are writing those products for them already to help them write more of it in most cases. But it's not coming out of their bottom line. It's coming out of Humana's bottom line, Aetna's bottom line, United Healthcare, wherever those co-op dollars are coming from. Most of the time, it's just coming straight from the carrier. And then they pass it to the agents 100% without peeling on the top. That would be an example of an ethical FMO. I guarantee you there's some out there that are like, ooh, we got $300,000 from Humana this year. Let's keep 100 and let's push 200 to the agents. I don't know. Or maybe they're just setting it on the block and going, hey, whichever agents want this money, come and get it. And for those of you that don't come and get it, we'll just keep what's left over. I don't know. Right? That's going to depend on the block. But I can tell you how it was at Precision Senior Marketing, where I worked at before I jumped back out in the independent world, started Avila. We would get a boatload of marketing dollars from a couple of different carriers. And I mean a boatload, like high-end 6 figures, pushing 7 figures, just for that one NMO. Because we run a lot of business. We're one of the biggest groups out there. We would pass that money through 100% at a co-op rate, right? And it's all based on a co-op. It requires the agent to have some skin in the game. And then we match it, right? So let's say, for example, you're an agent and you want some Humana co-op dollars that we have available. And your budget is $1,000. Well, if you spend $1,000, we'll pull $1,000 out of the Humana co-op and double your marketing budget to $2,000. Pretty simple, right? And generally it worked that you had to spend the money first, and it kind of still works this way. You got to go spend the money first. You send us the invoice, and then we cut you a check for 50%. This year, there's co-ops out there as high as 75%, as high as 100%. Or, hey, we'll just pay for your leads this year. There are definitely a few co-op deals out there like that. I'm not going to name any specific carrier names because I don't know who's getting those deals and who's not. But I guarantee you that in some NMOs, some FMOs, they are able to pass through some of those co-op dollars at a 100% rate. Meaning that, hey, you're writing ABC Carrier. Well, ABC Carrier gave us 100% co-op authorization. So you send us an invoice for $1,000. We're just going to give you a check for $1,000. We're going to pay for those leads. And please, we hope you write them with this carrier that's given us the money. But there's no control mechanism that forces you to write that business with that carrier. Ultimately, it's going to be on you. I mean, I got a bunch of co-op dollars this year. I probably shouldn't say this live, but I'm not biased towards the carrier that gave me the co-op dollars. I'm sorry. I'm not. Why am I not biased towards the carrier that gave me those co-op dollars? Because it may not always be the best product for my client. I'm going to write I appreciate your co-op dollars. Thank you. And I'm still going to write your product. And I'm going to write a ton of it. But when it comes down to that specific instance, that specific client, I absolutely will not say, hey, please buy this product because they gave me co-op dollars. I'm just going to write what's in your best interest. And then the next one maybe is that product. And if it's not, okay, fine, it'll be the next one. And if it's not, then it's not. I don't care. And if you don't give me those co-op dollars next year, that's fine, because thankfully I don't rely on co-op dollars to be successful in this business. I do appreciate them, and they help me reduce my bottom line and increase my marketing, but I don't rely on them. I don't need them to be successful, but they are useful. So CMS is going after those co-op dollars. They want to prevent any instance, they're calling them loopholes, compensation loopholes basically. They want to prevent any opportunity where a carrier or an NMO or FMO agent can say, hey, we got a bunch of money from ABC carrier this year. Here's $5,000 in marketing money to generate leads for you. Please go write them with ABC carrier. And I will tell you that in most cases, they're averaging that out at about $100 an app. I've seen some numbers a little lower, but usually it's about $100 an app, which means if you're getting $5,000 in co-op money from a specific carrier, they kind of want to see about 50 apps from you. And if they don't, then they may or may not give you money. But I'll be honest with you, I don't think any of them are monitoring it. I really, really don't think they're monitoring it. And I could be wrong, and there may be some instances, but I think most of them, with the state of the way, the state of affairs going on in the Medicare space, the amount of stuff that we have to keep up with, the amount of change that is happening on a rapid basis, I don't think any of them are keeping up with, oh, well, we gave Joe $5,000 last year. He only wrote 22 apps. So we're not giving him $5,000 this year. They're just going to go, hey, man, we got another big pile of money. Who wants it? Here's the rules. You spend 50, we give you 50. You spend 100, we give you 75, whatever it might be. You spend 100, we give you 100. Joe Camper knows what's up. I'll take that $5,000. That's like a farmer that gets paid for not growing corn. Hey, I don't grow any corn. I wake up every day. I go outside. There's no corn growing, but where's my check? That's Joe Camper right there. I don't write any Medicare Advantage business, but I want to get paid anyway. But that's what they're going after. They're going after all those little incentives above the $611 that we get as an agent to try to remove bias. What are some of those things? Well, one, we mentioned co-op dollars already, right? There's co-op dollars that come out like crazy, and some of those might even be from your FMO. Your FMO spread might be to the extent that he's like, hey, I'm making $250 an app over street on your business. For every 10 apps you write on this product, I'll bonus you $500 for marketing expenses. Those programs exist, and they've always been thought of as ethical. I think they're great. I have a program like that with agents that work with me on certain products. You write 10 apps of this specific carrier, my spread's good enough that I can kick money back to you to use for marketing to help you grow your business. I don't see anything wrong with that, but CMS does, because that incentivizes you as the agent to write one carrier over the next. Fine. That's fine. Other things that included in that money is your HRA payments, right? These HRAs are when you do your health risk assessment, right? Medicare Advantage will take anybody that can fog a mirror and has a Medicare number. There are no pre-existing condition clauses. There is no underwriting. If you can fog a mirror, you got a Medicare number, and it's an active enrollment period, boom, you can have a Medicare Advantage plan, no questions asked. But after you do that enrollment, many of the carriers will ask you to complete a health risk assessment, an HRA for short. And what that health risk assessment does is it lets the carrier know a little bit about that piece of business you just wrote. What is the health conditions of this client? What are their chronic needs? What are their prescription needs? What's their ethnicity, race? Like all of these different little questions that it asks them. And then the carrier will pay you for doing that HRA. $50, $60, $75. I think some of them might even be giving away $100 for completing HRAs. Now, I'm of the opinion that an HRA doesn't incentivize you to write one carrier over the next. Maybe I'm wrong, because when I'm writing business, an HRA doesn't pop up 100% of the time. I submit that app through Sunfire because that's the platform I generally use. And I don't always see an HRA pop up, right? Because I submit the app and then boom, it goes to the next screen. Hey, your enrollment's been completed. It's been signed. Now complete the HRA. It has a little button right there. Click here to start the HRA. If I complete it, I get more commission. But if I don't complete it, I don't get any more commission. But I don't, when I'm on the front end of that app and I'm talking to my client and I'm comparing plans and I'm going through all the motions, I don't know for a fact, unless it's new to Medicare. If it's new to Medicare, then I can pretty much guarantee an HRA is popping up. But in most cases, especially if it's a replacement app, I don't know that an HRA is going to pop up and allow me to do one. So why in the world would I be favored to a carrier that I know pays me more on the health risk assessment than another one? Hey, let me make sure I write Humana. And I'm just saying Humana arbitrarily, not picking on them. I love Humana. I write a ton of them. But I'm going to go ahead and write Humana because they're paying me more on the HRA. And then you get back on the back side of the app and you're like, shit, the HRA didn't even pop up. And then you did something maybe that wasn't in the best interest for that client. I don't know that anybody's operating that way. I could be wrong. You might be operating that way. One of the other incentives that they're looking at going after is called the VBE, and I can't remember exactly what VBE stands for. I know it's value-based, value-based enrollment. Yeah, value-based enrollment. That is when you are writing an app and you have an opportunity because maybe that person that you're writing doesn't have a primary care physician, and you're able to recommend a value-based care clinic in the area and sign them up with that PCP. And then you report to that value-based care clinic that, hey, I signed someone up with your primary care physician. Where's my cheddar? And they'll pay you extra money, $50, $60, $100, right? So in a lot of cases, you can write a Medicare Advantage app. You can make $611 on the front end for writing the app. You can get another $50 to $100 for an HRA, and you get another $50 to $100 by recommending them to a value-based care clinic. So now you went from making $611 to maybe $811. That's pretty lucrative. And I can definitely see why agents would want to try to get all of those check marks ticked. Believe me, I get a little bit angry when I see agents in my group that are writing business and they're not completing the HRAs, because let's just face it, that is just absolute laziness. It's a 5 to 10 minute questionnaire. Why you're not clicking that button and bouncing through it with your client? You shouldn't even be asking them for permission, in my opinion. You just click the button and like, hey, I got a few more follow-up questions to help the carrier manage their experience with you better, and then you bang them out and you make your extra money. But I don't see how those two items specifically, HRAs and VBEs recommendations, I don't see how that incentivizes an agent to write plan A over plan B. I guess I could in the VBE situation, because if you know that value-based care clinic accepts carrier ABC but not carrier X, Y, and Z, then maybe, hey, I'm going to tee this up. I'm going to write ABC. That goes to that value-based care clinic. I'll recommend them. I'll sign them up for that. And boom, I get more money. That might work. But that's what they're coming after. That's level 1 that they're coming after. Level 2 that they're coming after is the mid-level structures. And I'm going to pull this back up because I want to read it to you. Let me find it in here real fast. It won't take me long because pretty much everything you want to look for on this deal is on page 6 and 7. But they are looking to come after, well, I'm not finding this quick as I wanted to, but they're looking for those mid-level hierarchies. And this is an issue that they've got. And I really don't know how they're going to tackle this. I'm not sure how you can truly tackle this. But what they are looking to do is basically wipe out what they call it the regulatory framework that allows agents to get compensated separately. Agents and brokers compensated separately. So when I read that, I think of the hierarchical structure of insurance. You have it's a supply chain, right? It's a distribution channel. You have an NMO that's direct to the carrier, SNMO, SFMO, whatever ridiculous nomenclature. But you have an NMO that's direct to the carrier. He's the national distributor. And then he has an FMO below him. And then there's an SGA, super general agent. And then there's an MGA, and then a GA, and then the agent. And in some cases, there's even sub-levels out there. So when Joe at the bottom writes an app, everybody that's in that chain of command is getting a piece of the pie. That's the insurance world as most of us know it. Pretty much every product out there has some form of a hierarchical nature in it, at least in the life and health space, right? And it's true in the Medicare Advantage world in a lot of ways. Now, some of those levels are pre-built from the carrier, right? Let's say United Healthcare on the broker channel. All those levels are pre-built from the carrier. So when I write business, I'm getting paid directly from United Healthcare. And then the guy above me is getting an override directly from United Healthcare. And the guy above him is getting an override directly from United Healthcare. But not all the carriers have those pre-built levels. Some of them, let's say Anthem, for example, doesn't have those pre-built levels. Anthem is a single payer model. ACA, a lot of the ACA contracts run on this. There are some ACA contracts that you can get direct, right? But again, they're a single payer model for the most part. They're not going to pay multiple people directly for one sale. But that definitely exists in the Medicare Advantage world, but not all others, right? So Anthem's a single payer model, which means that either A, you're appointed directly with Anthem so that when you write an app, you get paid directly from Anthem, and that's all the money that exchanges hands, or you're contracted through an NMO or an FMO or MGA, and when you write Anthem, they get paid, and then they pay you. It's an LOA model, right? Anytime your commissions are assigned to a third party, it's an LOA model. License only agent is what that stands for. It means that basically your agent number is getting duplicated. You can write business, and then that group is getting paid just as they wrote the business, and they pay you. And some NMOs, FMOs, what have you, go to the added step of creating their own hierarchical compensation structure. And there are definitely agents out there, because I've talked to them, that will put their Anthem contracts with a specific NMO or FMO because they know that they can get the bigger overrides. Because if you just go directly to Anthem, unless you're writing a shit ton of business, you're only going to get the agent rip. Even if you're a G, I mean, you're going to get the agent rip. You're going to get 611. But if you put it through an NMO that's contracted with Anthem, and Anthem's like, well, yeah, these people are going to write hundreds and thousands of apps for us every year, so we're going to pay them a very high commission and let them filter it down, and they can build their own little hierarchy structure. And they will. They'll build the FMO, the MGA, the SGA. They'll build all those levels out and allow you to get more money. Doesn't necessarily mean you're biased towards writing Anthem over someone else. It just means, hey, if I want to tap into an override structure on Anthem, I have to go to an NMO or FMO that has a high enough contract that they can build those levels in themselves when they're administering commissions. But ultimately, at the end of the day, that NMO is the one that's getting paid. And then you're getting paid secondarily. And hopefully your contract on the side of that LOA agreement is worth its weight in gold. Because otherwise, maybe you should just be going direct to the insurance carrier and just taking your rip as an agent and moving on with your life. So CMS is going after that as well. They're going after all those little mid-level compensation structures. And either A, they're just going to say, okay, we'll let all of these mid-levels exist in a hierarchical structure, but the very top compensation at the NMO level is also capped, because as it exists right now, only us agents are capped at the writing level, 611, right? An NMO might be direct with United Healthcare. He might be direct with WellCare. He might be direct with Humana, and he's getting a different top level commission off of all those carriers, which absolutely can make him biased. And I'm not going to name any specific carriers and throw people under the bus, But there are definitely carriers out there that are paying NMOs a lot more commission for their distribution than the other guy. I will tell you that on average, most NMOs that are direct to the insurance carrier are getting around 225 to 275 over street. 250 is a pretty good average. There are some carriers, they're making a lot more though, for whatever reason. Some of the, and there's a couple of ways that happens. Some of the carriers, they're getting that money, but they're reserving it as the co-op dollars that they put out during AEP. Some of them are saying, no, we're not going to do co-ops. We're just going to pay you a much higher commission when you actually write business at the NMO level. So CMS is going after that spread above street because they see that spread as the opportunity to incentivize agents through bonuses, marketing dollars, etc. And let's face it, if you're an NMO, if you're direct to the insurance company, and this company, and I'm just going to use some arbitrary numbers, this company is paying you $900 an app at the NMO level, and this company is paying you $1,300 an app at the NMO level, which one do you want your agents to write? The one that's you're making 900, the one you're making 13. So I can definitely see how NMOs can be very, very, very biased and really do their best to steer their distribution through co-op dollars and bonuses. Like, hey, if you write this product for us, every 10 apps you write, we're going to give you a fat bonus. Or if you go ahead and write 20 apps, we'll do this trip on the side and we'll say it's out of our own money. Like, there's all kinds of ways to finagle it. And I know that there's groups out there, and you're not supposed to be doing this shit either, but there's groups out there that are like, oh, well, you don't quite have enough agents to get the FMO level or quite enough production to earn the FMO level. So what we'll do is we'll let the carrier approve your level at where it is, but then on the backside, we'll do some manual adjustments to pay you some overrides. Or we'll split our override with you. You're not supposed to be doing that either. And that happens. That happens. That's probably one of the most widespread problems that is occurring out there in the higher level distributions. Right? Or in some cases, maybe they have a group in their hierarchy that has outgrown them and now has the ability to maybe go direct to the insurance company. They'll say, hey, no. Don't leave us. We really like your production and we need your production. So here's what we'll do. Keep your contract with us and we'll split our override. Every quarter we'll settle up and we'll cut you a check for the difference that'll get you similar to where you want to be. That shit's happening. And it shouldn't be. And this is where CMS is all going after it. All these little loopholes that make the game to some extent unfair. Now, the other thing that they are looking, well, let me say this. Where is that going to lead us? Okay. If they go after all these mid-levels, are they just going to turn the entire game into a single payer model where every agent then has to go through either one designated NMO or a small handful of NMOs or you have to go direct to carrier and there's only one commission paid and it's directly to you? Now, we already know there's no way in hell that they're going to push us all direct to carrier. Won't happen. It absolutely won't happen where they say all of a sudden we're just going to wipe out all of the upper levels and every agent just goes direct to the carrier and the carrier manages it all. Won't happen because carriers can't do that. They don't have the marketing staff. They don't have the infrastructure. And they don't, and all truth be told, they don't have the skill set. There's a reason that carriers use NMOs and national distributors, and it's because those guys can do it more efficiently and they can do it on an incentivized basis, right? Where the carrier says, hey, we'll pay you this commission. You go distribute our product. And they handle all the marketing, they handle all the training, they handle all the distribution. All the carrier has to do is administer the business on the back end, right? Carriers do not have the infrastructure in their marketing departments to all of a sudden take care of 1 million insurance agents that are out there. So if they're doing anything like that, they're going to limit it to certain distribution channels, certain NMOs. Let's say, okay, these NMOs get the national contract. Everybody else has to go through one of them. And that NMO is going to have to prove that they have the infrastructure to administer commissions. And every agent that's under that NMO gets the exact same payment, no matter what it is, and the NMO just gets to keep his override as a cost of doing, or as his cost of doing business, or to help, make him profitable so that he can actually be in business. And that override will likely be too thin for them to provide co-op dollars in the first place. Or CMS might just say, hey, no, you can't do co-op and marketing dollars, period. Maybe that is outlawed, but I don't think so. I think where they're going to go with this is they're going to turn us all into LOAs under different distribution channels. And then it depends on which distribution channel is going to treat you the best. I've seen this happen before in the Medicare supplement space, as a matter of fact, not exactly the same way. But if you think that the insurance companies or CMS can't accomplish this, I'll give you one example. Aetna Supplemental. This was probably 5 years ago now. Might have been longer. It's been a while. But Aetna Supplemental decided they wanted to thin their national distribution partners. They had X number of partners, and they're like, that's too many. We want to trim it down to this number of partners. So what did they do? They went through and they're like, well, we're keeping that one. We're keeping that one. We're keeping that one. We're keeping that one. He's out. He's out. He's out. He's out. And then they went to all those distribution partners that were at one time direct with Aetna Supplemental and said, hey, you're cool and all, but you're not direct to Aetna cool anymore. Here's all of our new direct partners. You have 90 days to make a decision on which one you want us to move your contract to, or we're just going to pick one for you. But you're no longer at level 15. You're now maxed out at level 14, and you're having to go through one of these distribution partners. Blue Cross does it. How many of you have contracted with Blue Cross entity in your state only to find out you're not actually directly with Blue Cross? You're actually under some FMO or NMO that has the rights to push Blue Cross. I guarantee there's a bunch of you out there that are contracted to Blue Cross and you didn't even know that you're under some FMO or NMO out there that is actually receiving the payment on your business and administering it all. Blue Cross is just administering the paper. And that's going to vary from state to state because Blue Cross is different in every state, but that's one example. So if you want to know where I think we're headed in the future with the Medicare space, they're going to trim it down to distribution partners that know how to push the business ethically, have good systems in place, can prove that they can build out the proper compensation levels to administer the business, and then we're all going to be LOA to those distribution partners. And then hopefully we have a good LOA agreement that gives us some kind of vesting clauses and so forth. That's where I think we're headed. That's more of a long-term. Short-term, like I posted this recently in the group. Short-term, we're looking at this. We're looking at probably a loss in co-op dollars. Come 2025, there probably won't be any co-op dollars for you as an agent, right? Your FMO is not going to call you up during AEP and go, hey, we got a whole bunch of co-op dollars from Humana or whoever it is. How much do you want to spend? How much are you trying to write? Come 2025, those conversations will probably cease to exist. I might be wrong. I could always be wrong because, again, this is just all food for fodder. This is an opportunity for lawyers to argue over between now and then. But I would bet that 1 year from now, we're going to find out that co-op dollars are off the table. We will probably also see immediately, and I say immediately, I mean in the next year, 18 months, a restructuring of the compensation of all Medicare Advantage plans, which should theoretically give us more money because they are proposing a $32 bump on both Medicare Advantage plan commissions and drug plan commissions. Shit, man, I'm of the opinion that if they're going to give us $32 more on a drug plan commission, why don't they make that a proportionate percentage over to Medicare Advantage? That's a 30% increase. A little more than a 30% increase in your PDP commissions. Why don't you give me a 30% increase in my Medicare Advantage commissions too? But no, they're looking at bumping us up to about $32 more than what we're currently making. And then I'm of the opinion that they'll do that. And then second, they're going to cap the very top NMO compensation. That'll be the first thing they do, right? First thing they do is no more co-op dollars, no more HRAs, no more VBE bonuses. If we find you splitting overrides, you're going to get in trouble. If we find you incentivizing agents with trips and other items, you're going to get in trouble. And then they're going to thin that override down to make it even harder for NMOs to even do it. And let's be honest, I love NMOs. I used to work with one, but they want their override, man. And they'll be more than happy to say, oh, we can't give out co-op dollars anymore. Well, that's a shame. We just get to keep our override. Keep going right in business, Mr. Agent. So it's going to thin the herd in the FMO and NMO world because they're going to get reduced on their override. And what else is left for most NMOs now? I mean, it's such a race to the bottom for most of them anyway. They all have the same products for the most part. They all get the same tools for the most part. I mean, it's pretty much come down to service, contract levels, co-op dollars, and do they actually answer the phone when you call them, right? So again, short term, we're going to see a loss of co-op dollars, a loss of incentives through HRAs and VBE payments. Second level, midterm, right, we're probably going to see some form of a restructuring to a single payer LOA model. And then from there, they'll limit distribution channels down to the groups that can handle that type of business, that they're doing the volume, they've earned it, they prove that they're ethical, and they prove that they have the infrastructure to do a single payer model where they can administer commissions. And then they will not allow all of the hierarchy of mid-levels. There's one level, there's the NMO, and there's the agent. And there's some kind of spread in between that makes it just profitable enough for that NMO to pay a staff and actually answer the phone for you if you call. That's my thought process. That's my thought. That's kind of where I am on the whole thing. There was more stuff that I really wanted to talk about today, but I've chewed up the whole hour speculating and pontificating on this ridiculousness that CMS is throwing down at us. If I were to say anything to you as an agent on what you can do to prepare, would be to don't be like, oh my God, the Medicare business sucks. It's over. That's not it at all. Medicare business is here to go. It is here to thrive. It's here for the longevity, and it's only going to continue to get better. The outlooks from most people that I've read, talked to, that are, at my knowledge, are better, and there's plenty of people smarter than me about this stuff, is that Medicare business is here to stay, and it is going to thrive, and there is plenty of time to build a very lucrative opportunity within the Medicare space. But learn that the Medicare space is not one product. It's not just going out there and selling Medicare Advantage plans. Learn all the other products that live within that space. And as my buddy Pete Fournier says, become a Swiss Army knife of Medicare. And learn a few other tertiary products too. You should always be ready to pivot on a moment's notice. Right? A good salesperson should always know how to pivot. And that's a big part of what I wanted to talk about and train on today, but we'll have to save it for next time because we are coming up to the hour. So what other products exist in the Medicare space other than Medicare Advantage? We have Medicare supplements. We have drug plans. We have dental, vision, and hearing. We got hospital indemnity plans. We got critical illness plans such as lump sum, cancer, heart, and stroke. We got short-term care, home health care. Technically, annuities exist in the Medicare space. It's not a Medicare product, but it's the same client buying them. Final expense, same client buying them. So if you're working in that space, why are you limiting yourself to one product? Learn all of those products and don't try to learn them all at once. Learn one at a time. Pick up, maybe today's the day. Like, man, I've been doing good with Medicare Advantage, but I really want to learn how to talk about hospital indemnity. So go watch a couple of videos, pick up one good hospital indemnity product, study the shit out of it, and then start talking about it. The more you talk about it, the better you'll get. And guess what? If you talk about it enough to everybody, somebody's going to buy one. And then once you get good at that one, then go learn something about a lump sum cancer product. and why you should be pitching that. What's the benefits of lump sum versus cancer treatment products, and then start talking about it to all of your people, and you'll sell some, et cetera, et cetera, et cetera, right? And learn to pivot. So that's the lesson today. That's the long day. I really appreciate you guys tuning in and listening to me kind of pontificate and going over this for a while. Comment on the group, man. Let me know what you think about this. And again, a lot of these items, I'm going to post a few of these articles that I already talked about in the group. A couple of them are in there. And like I said, the entire Federal Register of that CMS proposal is up for public inspection. It is in the group. And I'm going to say one more final thing. I hope you're still tuning in. Don't leave just yet. You can make comments to the government about this proposal that they're pushing towards 2025. Comments, I believe, are open till somewhere in January. Somewhere in January. I don't remember the exact date. I'll find it. I'll get it in the group for you. But if I would advise you to make some comments. If you care about our industry, I would advise you to research what's going on, formulate an educated, well thought out opinion, and make some comments to CMS. Let them know how you feel. But I'm going to say this. Before you just head over there and make comments, take your time. Make sure it's well thought out. Don't just post some angry bullshit. This sucks. You people are terrible. Vote them all out. Drain the swamp. Lock her up. Don't be doing shit like that. Come up with a well thought out response on some of the errors in their judgment, how you ethically behave as an agent, and post good-natured, well thought out comments that are going to be a great example for our industry. Take your time. Check the spelling. Make sure the grammar's right. And I know that sounds silly, but I've seen some of the shit y'all write out there. Some of y'all ain't seen no dictionary since you dumb was in grade school. I'm being serious, and I'm not trying to be rude. But if you want to, don't just go making asinine comments to CMS about this, because all they're going to do is look at that as a bad example of why they should tighten up more. It's the same thing with why you should be making complaints to Medicare about other agents. I said it earlier. One asshole makes a bomb with shampoo, and the rest of us have to travel with shitty hair. So don't be that guy that makes the industry look bad by making complaints to Medicare about other agents, because all you're going to do is bring down more regulation. And don't make angry garbage post comments on the CMS website asking for comments about this proposal. Take your time, make them well thought out, make them grammatically correct, make them educated, make them look good, and they will pay attention to you and hopefully push this in the agent's best direction. We'll see. So thanks again for tuning in. That is it. We'll see you guys next week on Tuesday training. Have a great rest of your AAP and a great week.